All right, thank you for joining us today for one of our Creating a Better Future webinar series. Today we'll be discussing the truth behind immunotherapy. Is it right for you? I'm Jennifer Gertz, Executive Director of Food Allergy Canada, and our guest speaker today is Dr. Julia Upton. As many of you are aware, our organization is a national nonprofit charity and Canada's leading patient organization committed to educating, supporting, and advocating for the more than 2 million Canadians that live with food allergy. However, you may not be aware that we are completely reliant on the generosity of donors to fund our work. So if you are able, we would welcome you considering a donation to Food Allergy Canada to allow us to continue the work that we're undertaking. This session will start with a presentation from Dr. Upton, and then there will be time to answer questions. We really want to thank everyone for submitting your questions in advance, and I know Dr. Upton has taken a look at those and have attempted to incorporate many of them into the presentation today. We will have some time at the end to address a few more, and we'll do our best to address as many of them as possible. A couple of housekeeping items. First, note that this session is for informational purposes only and will not provide specific medical advice, recommendations, diagnosis, or treatment. Please talk to your doctor about any concerns or questions you may have regarding your own health or the health of your child. Secondly, all participants are muted so we can keep the audio clear for the webinar. If you have questions through the session, please submit them in the chat question box. And as I mentioned earlier, we'll try to get to as many of those questions as we can. And lastly, know that the webinar will be recorded and shared on foodallergycanada.ca afterwards in case you want to refer back to it or share it with others. Before I introduce Dr. Julia Upton, we'd like to do a quick poll around the subject, around the truth behind immunotherapy. Is it right for you? So if we can have the poll question go up. So those of you who are managing a food allergy, either yourself or managing a food allergy as a family member, the question is, if immunotherapy for food allergy was available to you today, would you consider it? Can you please select one of the following answers? All right, just a little bit more time to get our results. All right, so interesting. So 63% of our audience, the answer to the poll question is yes, and not surprisingly, there's a number that are unsure, and part of the reason why you're here today to learn from what Dr. Upton has to share with us. So that's terrific. We're going to go back to that poll question at the end to get a sense for where you are after having viewed the content and listened to the Q&A. So I'd now like to introduce Dr. Julia Upton. Dr. Upton is a Canadian allergist who is on staff at the Hospital for Sick Kids in the Immunology and Allergy Department, and she is an assistant professor in the Department of Pediatrics at the University of Toronto. Dr. Upton is chair of the Anaphylaxis and Food Allergy section of the Canadian Society of Allergy and Clinical Immunology and a member of the Healthcare Advisory Board for Food Allergy Canada. I know Dr. Upton has been extremely busy over the past several months, and so we're so pleased that she's been able to make the time to be with us today and to share her insights on immunotherapy. I'd like to now turn it over to Dr. Upton.
Great, thank you so much, Jennifer. So the truth behind immunotherapy, is it right for you? And I just want to mention a little bit about me and immunotherapy, that my immunotherapy experience is actually in clinical trials, and so the oral immunotherapy, multi-foods, as well as the patch. So I will still try to give you, a balanced picture of immunotherapy, of course. So today we're going to speak about the threshold of reaction, because it's really key to understand what immunotherapy is achieving. We'll also just talk about the processes of immunotherapy and desensitization, some recent updates and approvals and guidelines, and really this concept of shared decision making. So for this talk, we're really talking about a certain type of adverse food reaction. So when we think of the types of reactions that people can have to foods, they can have all sorts of different types, such as lactose intolerance or discomfort from greasy foods. And these are food intolerances. And today we're really talking about the immune-mediated food reactions. And within the immune-mediated food reactions, there's also lots of different types. So people can have celiac disease, which is an immune-mediated reaction to gluten. But we're not talking about celiac and that type of reaction. We're really concentrating on a very specific type of immune food reaction, which is caused by an IgE antibody. And this gives a risk of severe allergic reactions or anaphylaxis. And I know this audience is very familiar with anaphylaxis, but just to say it, so the symptoms of IgE-mediated allergy, the type of allergy we're talking about today, are skin symptoms such as hives or swelling, breathing symptoms, heart and blood vessel symptoms such as reduced blood pressure, and then gut or GI symptoms such as vomiting or cramping. So to understand immunotherapy, we'll just touch base about the typical treatment or standard of care for food allergy, which is avoidance. And so food allergic reactions generally occur after ingestion. It's quite rare to have any other route of exposure, such as skin exposure or inhalation, cause any kind of significant reaction. So reactions that appear to occur without known ingestions are really usually from contact of the food through transfer. So the bottom line is that avoidance of ingestion of the allergic food is the most recommended management for food allergy, as well as carrying an epinephrine autoinjector. But the avoidance of food allergens is actually very difficult. It requires planning, reading labels, asking lots of questions, making special meals, cooperation, coordination, really many other accommodations and processes that people without allergies don't even need to consider. And when we think about having a food allergy or not having a food allergy, we often think of them as being totally different, as symbolized here by a dark blue dot for somebody who has an allergy and a white dot for somebody who does not have a food allergy. And as allergists, we often treat everyone with an allergy the same, as if a tiny amount will cause a severe reaction. So we tell everybody to avoid the food and carry an epinephrine autoinjector. And then we may think of the state of not being allergic as no food restrictions at all, no concerns, no epinephrine autoinjector. The reality may be more like this, that people with food allergy vary in terms of the amount that triggers an allergic reaction. They're not all the same. And to elaborate on this, I will spend a few minutes talking about the threshold of allergic reaction, because it relates so strongly to what we achieve in immunotherapy. So just the word threshold. Threshold is an amount that must be exceeded for a certain reaction, phenomenon, result, or condition to occur. So in a picture, this is sort of the concept of the threshold of reaction. So the threshold, again, is the amount that must be exceeded for a certain reaction, phenomenon, result, or condition to occur, here in the gray area. And we're familiar with thresholds in many areas. The threshold of hearing, for example, is the amount of noise you can hear. So maybe these are tiny, tiny quiet whispers, and this is where you can hear. In the case of food allergy, the threshold is the amount of food that the body is kind of seeing or that the body has inside. And so we call this amount that triggers an allergic reaction the threshold, or the eliciting dose is another word that you might hear. So in this picture, you can see that if we think of this as the amount of food eaten, here some food was eaten and it didn't pass this threshold. There were no symptoms. And yet this time, this amount of food went past this line, this threshold, and caused a reaction. So the threshold is different between people, and the threshold is also different for the same person, which makes things a little bit more challenging. When we think of what kind of amounts are we talking about as a threshold? So it's estimated that about 5% or less, so 1 in 20 or less of peanut allergic people will have an allergic reaction to 1.5 milligrams of peanut protein, which is like 6 milligrams or so of crushed peanut. So to give a kind of visual idea of 6 milligrams of peanut, it's 0.0045 of a teaspoon of peanut butter, that's like the natural kind with no fillers, or about 1/225th of a teaspoon. I was able to find this picture on Amazon of what 6 milligrams of peanut kind of looks like. So this is a picture of a very, very small spoon. It's a volume spoon, but it correlates to a weight with most powders. So it measures about 6 to 10 milligrams of most kind of powders. And just to give an idea, and obviously that's an American penny. So less than 5% of people would be expected to react to that amount. One of the issues, though, is that the threshold is not stable. So the threshold of an allergic reaction changes due to other contributing factors, and we often call these cofactors. So these cofactors, there's many, but some of the most best described are exercise or illness or medications or alcohol or asthma control. So these can lower the threshold of reaction. It's actually kind of hard to predict the threshold to which someone will react. In studies and in clinic, we use oral food challenges to have some threshold information. So here's a picture of an oral food challenge. In this picture, I've used almonds. And so here, this would be the weighed amount of almonds that someone might eat in a medically supervised oral food challenge. And so they would start with that little bit, and then we would wait about half an hour or so and see if there was any reaction, and then give more, and then wait, and then give more, and then wait. And so we would do this until there's signs of an allergic reaction. So this oral food challenge can actually prove the allergy. You can imagine if the person reacted here, then we would say that was the threshold of reaction or the eliciting dose. But it can also clear the allergy. Often when I think it's just worth mentioning that often when we do oral food challenges, we find that the person's not allergic. In the context of immunotherapy, this is often done at the beginning of studies to see how much triggers the reaction. So why does it matter? So like I said, it helps us to understand how much a person with an allergy can eat before they will have an allergic reaction. And maybe there's help for this with labeling, what amount contains or doesn't contain, and that would be another talk for another day. But Food Allergy Canada has been quite instrumental in helping with labeling, because if we can use this information better in the future, then maybe people on avoidance can understand how careful do they need to be, what's may contain, what's an accidental exposure. In the context of this talk, though, we're interested in the threshold because of the response to food immunotherapy. So this is some mathematical modeling, just to illustrate a concept. So here the researchers estimated that there would be some peanut cross-contamination in snack chips. And again, this is just mathematical modeling, it wasn't real life, but they estimated that if you buy a bag of chips, there would be sometimes a certain amount of peanut in them if they're not sort of certified peanut-free. So then they estimated whether a peanut allergic person would have an allergic reaction to this theoretical cross-contamination, and it would be dependent on their threshold. So again, in mathematical modeling, they thought about, okay, well, if somebody has a threshold of reaction of only 1 milligram, remember that's very, very low, then they would actually have a pretty large chance of having an allergic reaction if they ate these chips. Whereas if you look, as this threshold increases, the chances of having a reaction to cross-contamination actually goes way down. So for example, someone who can eat 300 milligrams of peanut without having an allergic reaction would be mathematically estimated to have a pretty low risk of reaction to an accidental cross-contamination in store-bought foods such as chips, in this, again, in mathematical modeling. So that sounds great. It sounds really helpful. That would help me a lot. But of course, it's really not as simple as mathematical modeling. And as we touched base about earlier, the threshold changes. So just to bring this picture up again, here we have this threshold of allergic reaction. Then we remember the cofactors. And so these cofactors actually lower that threshold. And so here you can see that the threshold can drop with these cofactors like exercise or illness or medications. And when we see that in a picture, we see that now all of these exposures that previously were tolerated might cause an allergic reaction. The interesting thing, though, is that if we accept that the threshold can be reduced, which it can, it follows that you can increase the threshold. And just looking at this picture, imagine if instead of putting the arrow down here, I put it way up here. And that's what immunotherapy does. So immunotherapy increases the threshold at which an allergic reaction occurs. And really this concept of being able to move the threshold of allergic reaction, change the amount of food that causes an allergic reaction is the concept. So here's this picture just showing again, and there's just partly I'm just introducing some other terminology because I know we're not consistent at all with our terminology in the food allergy field. So, but if you can increase the threshold, then we think of you as being less sensitive to the food or desensitized. And again, if we think back at our hearing example, if somebody's hearing is really, really sensitive, then they can hear very quiet sounds. If their hearing is not sensitive, or if they've been desensitized because maybe they went to a loud rock concert or something, they'll need a louder sound to hear it. So let's go back to our mathematical modeling, just because it's so clean rather than real life. So imagine that you're somebody who reacts to only 1 milligram. And now after oral immunotherapy or another technique of immunotherapy like the patch or sublingual, we can bring this threshold up to 10. So you can see that this would go along with a mathematical theoretical reduction in the risk of reaction to, again, these same snack chips. So it shows that the threshold the person starts with and what they end with after immunotherapy, and that if you can increase it, that the idea would be that you would reduce your chances of reaction. And so let's now move on to the immunotherapy approaches. And so there's different types of immunotherapy that's been explored for food. So there's oral immunotherapy, which I've shown as a stomach because it's eaten. There's sublingual immunotherapy, where the food is put underneath the tongue. And then there's epicutaneous, where it's a patch that's applied to the skin. And so we'll just touch base about the dose and dosing, how well it's thought to work. And when we say work, what we mean is increase the threshold, the side effects, the safety, the ages, and can you get it? So in terms of oral immunotherapy, the daily dose has been quite variable in the studies. I mean, now there tends to be this focus around 300 milligrams, partly because that's what the pharmaceutical product in the US, Alforsia, used. So higher and lower amounts have been used. For sublingual, it tends to be a lot smaller. You can imagine you have to be able to get those, that food dose or peanut, for example, you have to get that amount of protein under your tongue. So it's a small amount that needs to go under the tongue. And then the epicutaneous is a very small amount, 250 micrograms, which is 0.250 milligrams, just to put them all in the same unit. So it's a very small amount that's being seen through the skin. Then in terms of updosing, and I'll have a picture of oral immunotherapy coming up, but essentially there's usually an initial dose escalation and then a build up. Sublingual, there's a few updoses. And epicutaneous, the way that the company is doing it is there's a single dose on the patch, but then they tend to have the patch worn for an increased amount of time. So sometimes you read that epicutaneous doesn't have a build up. It doesn't have a dose build up, but arguably there's a build up because the time that you wear the patch is increased, at least in the studies. And then they're all currently used daily, certainly during the initial stages. And then how well does it work? And so I have it in quotes just because, when we think back to that blue dot and white dot, like I don't know that we're talking about going from a blue dot to going to a white dot. We're talking about increasing the threshold. And so people talk about oral immunotherapy that it increases the threshold a lot. It's often multiple times the amount that's being eaten daily, and I'll show you a picture. Sublingual, sometimes it's sort of boiled down to medium working, but now we're seeing long-term studies that are showing that after years, it may be approaching the effect of oral immunotherapy. And then epicutaneous, again, it probably increases the threshold less than the others, although again, this effect increases over time. And so I think it remains to be seen what the end result will be. In terms of safety, systemic reactions occur, and often up to about 20-ish% of people will drop out of oral immunotherapy, often for GI symptoms or stomach symptoms. And some studies have more or less dropouts. For sublingual, it's mostly localized mouth symptoms, but people don't tend to like those. And so there does tend to be a similar dropout rate. even though there's less systemic reactions or anaphylaxis than oral. And then epicutaneous has the lowest dropout. It's mostly local skin reactions. The availability of oral immunotherapy in Canada, there is not that pharmaceutical product, I will say, yet, because it probably will come, but currently we do not have the pharmaceutical product that many of you have read about in the news. So providers that are offering oral immunotherapy in Canada use store-bought foods, or they actually get a pharmacy to make capsules out of crushed food or powder. Really, in theory, any food as well as multiple foods are possible. For sublingual, there's no licensed product and there's no widely available, it's really not widely available with normal food. So it hasn't come into the clinic quite the same way as oral immunotherapy has. And then epicutaneous is a pharmaceutical product. It's currently only available in studies, and it will be limited to the foods that they make. It's not the same as just taking peanut and putting it on the skin. It has it has a like a chamber with the food in it, and it will need to be the pharmaceutical product itself. Then in terms of the age, oral has been studied in all ages. Certainly there's more information, and it appears to be more effective in younger groups, although I'll show you that young kids are a little bit challenging because a lot of them outgrow it on their own, and so it makes it a little bit harder to study. And then sublingual has mostly been studied in kids, and epicutaneous, the company is currently concentrating on the lower age ranges. And sorry if it's not clear in this table as I look now, the epicutaneous is not commercially available yet either. We don't have a commercially available or pharmaceutically available immunotherapy product in Canada, but the oral immunotherapy is being used with just foods you can get or that are locally encapsulated. We have a webinar from September of 2018 and that goes really through in quite extensive detail about oral immunotherapy. And so I did want to touch base about oral immunotherapy here just because it's the only one that is remotely available in Canada outside of studies. And but please, for more in-depth information, you may need more than this. So I'll just touch base about the process. So this is really an overview of the oral immunotherapy process. And I've used milk in this picture because I know many people feel like peanut gets all of the attention. So in terms of the beginning of oral immunotherapy, allergists and many of the regulators agree that a person considered for immunotherapy should be food allergic. So therefore, an oral food challenge to prove the allergy may be the first step if it isn't clear that the person is allergic. And then then they start, if they are allergic to the food, then a small amount of food is given under medical supervision. And what happens is that amount is eaten at home, and then they come back to clinic to have what we call an up dose or a dose escalation, and then they again eat that amount at home, and then they come back to clinic and have an up dosed or dose escalated, and it just keeps going up and up and up and up. So the intervals between the eating it at home and then coming back is often about 2 to 4 weeks in most protocols, but there's variability there, and it's like going up rungs in a ladder. You just keep increasing the dose in a medically supervised setting and then eating it at home. This phase can last like 6 months or even more. Sometimes with multi-oral immunotherapy, it can take quite a bit longer than that. And a person may go up a dose and then have a reaction and then have to go back down a few rungs and then have to come back up again. So eventually about 80% of people who start this process will reach a top dose. And again, the top dose isn't fully defined. A lot of people are coalescing around 300 milligrams these days, but there isn't just there isn't one dose that's been used. But eventually you reach a maintenance dose and then continue on that. So in previous studies, people have tried stopping that maintenance dose to see whether or not the person remains allergic. And they call that sustained unresponsiveness. I have not put that in this slide just because in general, we aren't stopping it these days for most people because it really seems that people need to keep eating the food. Another piece that some people do is to do another oral food challenge. Because if this was the amount that you reacted to and this is the amount that you're eating every day, now we want to know, okay, well, how much can you eat? And we actually find that the amount that someone can eat in the oral food challenge while they are on their maintenance dose actually tends to be quite a bit bigger than the amount that they're eating every day, which is why I made that milk picture bigger. So in terms of the process, really every area of the process can vary from one study to another and one office to another, and the exact regimen can vary within patients at the same office, even within the same studies, because there's flexibility to go up or down doses. So a person may go up and have a reaction and come down, and some people won't be able to continue. And I apologize, I switched to milk to be inclusive, but I left nut there, so I'm sorry. But you know, the idea is that each one of these varies. So not everybody does an oral food challenge at the beginning. The time that it takes to go up can vary. The time in between the visits can vary. This target maintenance dose can vary. There's a lot of variability in the protocols. So you could view this as, oh, well, that's, you know, confusing. Why doesn't somebody have one way to do it? You could also think of it as there's a lot of ability to personalize oral immunotherapy. So this sounds pretty good. I like the personalization. So what's the controversy? And you know, to boil it down to one thing, I think that physicians agree that oral immunotherapy increases the threshold. So meaning the amount of food that a person can eat in a food challenge. But does that really mean that the person is protected to the accidental exposures of the food? And so the studies have looked at eating the food deliberately, those oral food challenges, that one at the beginning and then the one after you go to maintenance. And they assume that it will give protection to the other times that it's eaten accidentally. So even though the threshold is increased, which we know through those oral challenges, people on oral immunotherapy actually have more allergic reactions than people avoiding in most of the studies. And so again, the physicians who maybe think that this isn't ready for clinical practice or aren't keen to recommend it, they think about, well, you know, if your concern with your food allergy is having allergic reactions, why would you want to have more allergic reactions? And so when you think about it, you know, the person on oral immunotherapy is eating the food every day. And so sometimes they're going to have reactions to when they eat the food because of that threshold variability that I showed. The risk of allergic reactions likely decreases with time on oral immunotherapy, although not every study has shown that. So just to do a bit of deeper dive on this, each dose of oral immunotherapy has a small risk of allergic reaction. And there's many doses because you're taking one every day. So let's just you know, for numbers' sake, let's pick that maybe there's a 2% chance of having an allergic reaction, a 1 in 50 chance, but the food's eaten every day, so there's going to be a lot of reactions. So the allergy field is getting better at understanding what people want and that people are different. And so some people don't mind that daily risk of a reaction because it's under their control. And you know, some people feel very differently about taking a dose and having a risk of reaction under their time frame, under their control, than worrying about other people's attention to their food avoidances and worrying about restaurants and things like that. So really people are different, and not everyone defines success as no allergy at all. Some people are happy to have this feeling of control over the allergy and the theoretical reduction in the risk of accidental exposure. Another thing that people about oral immunotherapy and quality of life means not everyone that's on oral immunotherapy will be allowed to eat the food. So for example, in the pharmaceutical product in the US, the product monograph says that you continue avoidance. So the purpose, you know, their marketed purpose of the immunotherapy is accidental exposure protection, not allowing you to now incorporate the food into the diet. Again, not everybody sees that as a problem. Not everybody wants to eat a peanut butter sandwich. Not everybody wants to drink a glass of milk. So it really depends on, you know, a lot of the decisions about immunotherapy really hinge on what's important to you. So again, physicians agree that oral immunotherapy increases the amount of food a person with food allergy can eat. And there are some studies that increases quality of life in some patients and families. I think most of us agree that this is a treatment and the individual remains allergic to the food. and that the allergic reactions on OIT decrease over time, but they don't go away for everybody, and not every study has shown a decrease. So back to avoidance, let's just think also about avoidance, because avoidance isn't risk-free. So on avoidance, some studies have shown that it has about a 13% per year have an accidental exposure. So 66%, this is a Canadian study, 66% were moderate to severe, and there was an underuse of epinephrine in this group. Fatalities are very, very low in food allergy, luckily. In oral immunotherapy, upon eating the dose, it's about 10 to 20% used epinephrine for a reaction during the updosing. And stomach pain, anxiety, allergic reactions probably cause about 15% to stop. This is from a community practice rather than a study that's very formally tied to a particular protocol. Some people get eosinophilic esophagitis, although some people on avoidance get eosinophilic esophagitis as well. And then I won't mention more about it here than just this. This really goes along with those cofactors, the idea that what can happen is you can eat the food and then be fine, but next day you eat the food and you go for a run, and then that triggers an allergic reaction because exercise is a cofactor. So the years of studying oral immunotherapy has now helped us to understand this. And so for most, if not perhaps all, oral immunotherapy protocols, people are advised to avoid exercise for a few hours after the dosing. And just to mention it, the risk of EOE, it comes up a lot. I mean, this is a different type of food allergy where eosinophils build up in the esophagus. And in a little kid, it can affect the ability to eat and grow. It usually resolves, for people who develop this during OIT, it usually resolves after stopping the food. And some allergists actually do go back on it now. But GI symptoms are really the #1 reason in most studies that people stop OIT. And it's just important to mention that EOE affects people who never did OIT as well. We get asked a lot what happens in the long term on OIT. So it does seem pretty clear that the longer the person's on OIT, the longer they can go without eating the food and stay in remission. Again, now in 2020, most people are not recommending coming off the oral immunotherapy. It tends to be a treatment that they're intending to keep for now, at least, until we understand better how we can predict people who don't need to keep it on. But in general, you should probably think about that most people who start will need to be on for a prolonged period of time. And but still, in the studies, if you're on it for many years and then stop it, it seems to be that the effect lasts longer. So that's good. The issue though is, and I think I've touched on this a few times, is that if the food's not eaten, the allergy comes back in a lot of people. I do want to mention the natural history of food allergy. So to understand the long-term effects of oral immunotherapy, it is important to show the natural history of food allergy. And so this graph shows that over time, some people just outgrow their allergies. And many of you may have had that experience, that your child or you may have had a number of allergies and now is left with less of them, even though no immunotherapy was done. So the challenge though for studying this and being able to say how well does it work in terms of a cure, that the allergy is fully gone, is that you can imagine if you're studying a food that has a high rate of being outgrown, like milk or egg, then it can be hard a number of years out to know what was the effect of the immunotherapy and what was the effect of just the allergy being outgrown. Because you don't tend to have a control group or a group not on immunotherapy for years and years and years. Most of the studies were designed that you have somebody who is getting immunotherapy and then somebody who does not for, let's say, a year, and then that group gets it. And so you don't tend to have somebody 5 years out where you have a group that had it and a group that didn't. So, it's just that it becomes difficult. If there's a natural rate of outgrowing, it becomes difficult to know a number of years out which part was which. It's also important to touch base that very allergic people can have allergies after avoidance as well. So kids with bad eczema can develop food allergy from avoidance of foods, and allergists advise to keep tolerated foods in the diet. So again, some of you may have had the experience that that you used to be allergic to something, and then you had an oral food challenge, showed that you weren't allergic, but you were still told to keep eating the food. So allergists advise that even after a past oral food challenge, the food is kept in the diet to try to avoid the allergy coming back. And so people who don't have an allergy are advised to have exposure. People who used to have an allergy are advised to have exposure. So it kind of makes sense that maybe some degree of ongoing exposure is expected to be needed for people on immunotherapy. And to go back to my blue dots, we made the blue dot, the allergic blue dot, multi-shaded to reflect that maybe not all allergic people are the same. And so I think that we should maybe make the not allergic people a little bit shaded as well, because I mean, really there are people who are not allergic, but they're at risk of becoming allergic by avoidance. Or there's people who are not allergic, but they used to be allergic. And if they avoid, then they're going to get the allergy. They have a chance of getting the allergy back. So probably it's not quite as distinct who's who. So I think my message there is just that OIT is a treatment that likely needs to be continued. Some people require the food in their diet, and if they stop, they become allergic. And my other message is just that because kids with milk and egg allergy outgrow the allergies so in such a high frequency, it can be harder to study the effect of immunotherapy. And I think this gets to one of the reasons of this common question of why peanut, why peanut? Why is there such a focus on peanut? And it's partly because it's one of the ones that's just less outgrown. And so it's if you want to be able to show does a treatment work, it's going to be a group that's easier to show that a treatment works or doesn't work, because on their own they don't have the same rate of outgrowing it. So here's a few updates on what the physician organizations say about OIT. So the American Academy of Allergy, Asthma, and Immunology, and I have the link there at the bottom, they do now mention Palforzia, which is the pharmaceutical peanut treatment, on their website. And they mention that egg and walnut allergy programs are being announced and under development for that, for a pharmaceutical product. And they mentioned that there's a relatively small number of allergists across the country who use commercially available food products to offer OIT in their offices. And this is a clinical practice which is not and will not be approved by the FDA. And what they mean by that is the FDA does not, they don't cover the practice of medicine. The FDA is about the pharmaceutical products itself. So it's not something, using store-bought foods is not something that will fall under the jurisdiction of the FDA. So in Canada, the CSACI, the Canadian Society of Allergy and Clinical Immunology, made 38 recommendations for the practice of oral immunotherapy. And the idea was that it was based on evidence and considerations of risks and benefits, as well as the healthcare system and patient preferences. This is open access. I do have the link here. It's definitely, probably more for a medical audience, but it is available. So, and sorry, I'll just mention these 38 recommendations. Some I've sort of sprinkled throughout, but we'll focus on a few of them now. So who may be good candidates for OIT? So in research, clearly studies have different objectives and different plans, and so the candidates for particular studies can vary quite significantly, and available trials are usually available on clinicaltrials.gov. But for clinical oral immunotherapy, the CSACI statement says that food allergic without contraindications could be considered a candidate for OIT, so long as they have a clear understanding of the risks and the benefits. And we get asked a lot, what about the very allergic? So studies and clinical offices have performed oral immunotherapy with very allergic people who have a history of anaphylaxis. And the difficulty is that the risk of reaction and being severe are actually quite difficult to predict. It also doesn't necessarily correlate with the psychosocial impact on patients and families of food allergy. So this paper talks about that the aim should be to make oral immunotherapy available as an option for all patients who wish to receive it, provided there's no contraindication and a clear understanding of risks and benefits related to them. So who are not good candidates? So uncontrolled asthma is an absolute contraindication. Asthma has to be controlled and proactively managed because we know one of the biggest risks is uncontrolled asthma. Pregnancy is an absolute contraindication for initiating oral immunotherapy as well. And that's common for all immunotherapy. Like you wouldn't start, pollen immunotherapy in pregnancy either. So conditions such as bad eczema or severe atopic dermatitis, EOE, like we mentioned before, heart disease, some medications, we have to really think about the risks and benefits in those situations and control them as best as possible. And they may be a contraindication. And then patient or caregiver specific contexts that may make this higher risk should be considered. So for example, if someone has a reluctance to use epinephrine, or if there's severe anxiety, or if sometimes there's family dynamics where one parent is keen on it and another isn't, or lack of schedule flexibility. You remember that going up the rungs there's a lot of medical visits. So if these can't be satisfactorily addressed, then they may be they would be a contraindication for OIT. What about really young children? So again, in September 2018, I talked about this a little bit more, but I wanted to update with a Canadian study. So in Canada, there was like a real world study on peanut oral immunotherapy in 270 kids, and 243 of these reached maintenance, which is great, and only 10% dropped out. So some did have reactions, and about 4% of these kids needed epinephrine. So during the treatment, the overall conclusion was that it was relatively well tolerated for OIT in this age group, and that they had a very high rate of being able to achieve this maintenance dose. And in this study, they used 300 milligrams. Some people ask, is a real cure in young kids? Like, meaning, is this the group that you could do OIT for a period of time and then come off it? So far we don't know that. And as I talked about a bit earlier, considering the fact that even people who naturally outgrow it, we want them to eat it, I think the overall feeling is probably people need to keep it in their diet. But there is a study called the IMPACT study that is looking at peanut OIT in very young kids, and then they're going to stop it and see whether or not the symptoms of allergy come back. And I have the link there. I recently checked, the results aren't in yet. So what about older children and adults? So there are definitely fewer studies in adults than kids, and there's evidence for increasing the amount of food, even in adults. So increasing that threshold, it has been shown for adults, but it's not as, the number of studies are less, and the results haven't been as robust. So the European Academy of Allergy and Clinical Immunology concluded that there wasn't strong evidence to use OIT in adults, whereas as I mentioned earlier, in Canada, we concluded it's a risk-benefit discussion for the adults. So should someone do OIT? So you probably realize so far that I can't tell you whether you should do it or not, because it's really a personalized decision of what makes sense to you, which parts of having the food allergy are the most frustrating. If someone wants to do oral immunotherapy because they want to get rid of the epinephrine auto-injector, 3 weeks from now, that's not something that we can achieve. So some of the reasons that people think about yes to immunotherapy are quality of life issues, social exclusion, anxiety. I've met families that they aren't comfortable, going to camp or sleepovers or things like that because of the allergy, and then doing something like oral immunotherapy opens up opportunities for them that they weren't comfortable with before. Some people like the idea of taking an active role. So even though there's that risk of having the allergic reaction, some people really feel more comfortable with that risk being under their on their watch, if you want to think of it like that they eat the food, and then they know that there's this few hours where they're at this risk of reaction, but they know they have their epinephrine auto-injector. They've been highly educated about food allergy. They're ready, they feel comfortable with that. This idea of accidental exposure protection, which is partly theoretical because not quite the way the studies were done, but there is, hopefully the purpose of immunotherapy is the accidental exposure protection. You have to be able to, accept this risk of allergic reactions. If avoidance is very, very difficult, although again, there's a caveat on that, that really most people on OIT are being asked to avoid free eating of the food. And then there's considerations of which food, I mean, if it's a food that's very highly outgrown and it's a very young person, maybe they want to wait. On the other hand, maybe there's more evidence that it works better in young kids and is easier to do. So, again, these are all issues that that need to be kind of addressed in a personalized medicine type way. And then in case it's a cure, I have it there with a bunch of question marks. And what does that mean to you? So I've shown you that increase in threshold is really what we think we can achieve. And reasons, that you might think, oh, I'm not so sure about that. There's these risks of allergic reactions, and they still require carrying the epinephrine and the readiness to use it. It requires a management of the doses, the sickness, the exercise, the cofactors. And so, people that are very, very athletic, for example, can sometimes have difficulty finding the time to have the food, although typically they can, but just things to think about. I didn't mention it a lot in this talk earlier, but some of the markers of success tend to be the markers of the lower allergy, but really people with high numbers can also succeed, which is why the CSACI statement kind of said that it should be open to anybody. There is this likely ongoing need to eat the food, at least in the near future. Many people still have to avoid. The cost and the time, the way most of these protocols are now, remember the rungs going up the ladder, there's quite a lot of visits. And then of course accessibility, and we'll touch a bit more on that. It's not clear that quality of life improves for everyone that does immunotherapy. A lot of it depends on how dissatisfied you were with the current management. Yes?
Dr. Upton, just so you know, we want to be able to move on to some questions shortly.
Absolutely.
So
yeah.
We've got a few that came in, so.
Perfect. So I just want to say, it feels like maybe we have a lot of things we don't know, but we have learned a lot. We know now that we thought initially with immunotherapy that this would be a cure. Now we realize that it's probably more sustained unresponsiveness, and in some people quality of life, or just an increase in threshold and accidental exposure protection. And then there's this really strong importance of managing cofactors, so dosing on a full stomach, reducing doses, and then the early studies used very high amounts, and now it tends to be coalescing around 300 milligrams. And like I said, we understand most people are really still allergic. We're being asked a lot, why is OIT not practiced on a large scale in Canada? So there's really less than 250 World College allergists across the country, and so it's challenging to offer treatment with multiple visits and a lot of education. Then there's reimbursement issues and this idea that physicians don't typically solicit patients in Canada. And are there any other choices? So, as time goes on, there have already been protocol improvements. Sublingual immunotherapy, is not currently widely available and maybe has a different risk profile. There is an emerging study of using medications with oral immunotherapy to try to reduce those reactions. And then there's other investigational products, which I won't get into currently. And then like we talked about a bit at the beginning, these efforts continue to understand who needs to avoid tiny exposures so that not everyone is treated as if they're at super high risk. We also need to think about how we compared oral immunotherapy to really strong support and allergy readiness and education and asthma management in people who avoid. So if you're considering it, maybe thinking about goals of therapy, if, does the physician offer after-hours support? Do you have commitment to this long-term process? And then all of these education pieces about needing to manage cofactors. Because these are active, both of the approaches for food allergy are active. Avoidance is actively avoid, and immunotherapy is actively expose. And I'll just end with this, that, you know, there are similarities and differences to OIT. I mean, and this is really highlighting the similarities, that both are carrying an epinephrine autoinjector, both are expected to use epi for acute reactions. Both are really thinking about this every day. There's a daily burden of vigilance is the word that some people use. Knowledge is helpful to both. Controlling asthma is a top priority. They both have a risk of EOE. And then there's this cure question, you know, I mean, some people outgrow it, but we still want them to eat it. And some people may have this sustained unresponsiveness, but we still want them to eat it. So I hope I've provided some education about immunotherapy and explained why there's enthusiasm and then some of the controversies that still remain.
Awesome. Thank you, Dr. Upton. I'm going to ask you to turn on your video, and I'm also going to suggest that we go a few minutes after the hour to be able to take a few extra questions, because there's a lot of content, and you covered off a lot of the questions that were submitted, but we've had a few more come in. I'd like to start with some clarifying terminology, because I think this is important. There's been lots of new terminology that has come up through this. And if you could speak to, you know, what's the difference between immunotherapy? Is it the same as food desensitization? Because it seems like those terms are used interchangeably.
Yes, so I guess I would probably say immunotherapy is sort of the process of achieving food desensitization, but you know, essentially it's talking about the same thing. Yes. Okay,
and how is desensitization different from outgrowing an allergy?
Right. Yeah. So that's a great question. So you know, just you know, and we showed some of the pictures about that, that there is a proportion of people that just naturally outgrow their allergies. So they're avoiding it, but then it goes away on its own. Whereas when you're doing this immunotherapy or desensitization, where you're in the oral form anyway, we're actively going up the rungs of the ladder, if you want to think of it like that, and kind of pushing this process along. We're almost artificially increasing that threshold. And when we stop, then the threshold drops. And you know, as I tried to make clear with maybe my colorful blue and white dots, that the distinction is perhaps not as clear, because even people who naturally outgrow, if they avoid for a long, long time, the allergy can come back. And so there really is almost this blurring of the difference, but certainly the desensitization, you know, we can tend to get somebody to multiple, you know, hundreds of milligrams within about 6 months. And so there's an active process to the desensitization or to the immunotherapy, as opposed to kind of, you know, waiting to naturally outgrow.
And so if a child does outgrow, do you have recommendations on keeping the food in the diet?
We do, yeah. So the practice here is that we recommend that the person continues to eat it 2 to 3 times a week.
Great. Okay. Now let's move on to the conversation around other allergens. There's lots of conversation on immunotherapy around peanut, as you said, egg, and somewhat milk. Can you speak to us about what other foods have immunotherapy options, and is there an option for multi-allergen immunotherapy?
Right, so you know, in theory, really any food can be used for immunotherapy, and some have tended to be, definitely peanut has been the most studied, but really any food can be used, and multiple foods can be used. One of the issues with using any food is, for example, something like shrimp. What often happens in a food like peanut is that you might go from tiny weighed amounts to then being able to eat something recognizable, like half a peanut or something like that. Whereas, you know, do you want to eat a tiny bit of shrimp every day? Because, you know, if we go through all of this process and then you can't keep it in that little bit in the diet, then it becomes more difficult. So, but it can be done. I mean, there's studies on almost every type of food, with the most data on milk, peanuts, and eggs. And for multi, so when you put multiple foods together, you can desensitize them. It does tend to increase the time frame that's required because, now you're having, if we think of that threshold of reaction, you have all these different foods at the same time, and it can, you often have to go a lot slower and start with a much smaller amount. And so it does tend to take a longer period of time, but it can be done. And it's just, it probably requires a bit of expertise.
Okay, now what about for oral allergy syndrome? Is immunotherapy effective for oral allergy syndrome?
So oral allergy syndrome is interesting. Oral allergy syndrome is actually a pollen allergy. So you're allergic to trees, for example, let's say birch. And then because you're allergic to birch, you get mouth symptoms to foods that are related to birch pollen. So things like apples and peaches and things like that. And actually the studies have been a little bit mixed on whether or not the pollen immunotherapy makes a difference to the oral symptoms of pollen food syndrome. But basically that tends to be a process that's more managed on the pollen side than the food side.
Okay. Thank you for that. Now we had some other questions around, and it might be helpful around desensitization if you can stop the therapy, right? So when someone is kind of hit those maintenance doses or that desensitization, can you just restate kind of the insights that exist around that?
Yes, so if you stop, then that threshold tends to come back down again. So again, if we think of the graph of the oral immunotherapy or the immunotherapy has increased the threshold, if we now stop that exposure of the food, then that threshold comes back down again. So meaning that you now start having allergic reactions to a smaller amount than you did when you were eating it every day. And that's been shown pretty convincingly, that if you stop it, a large proportion of people have that threshold come back down again, meaning that they react to smaller amounts of food than they did before. So currently we are, I think the expectation is that if you begin oral immunotherapy, you probably need to keep the exposure in the diet. How that looks exactly might, it will evolve over time. And so many people are interested in what's the minimum amount that somebody has to do. So let's say milk, for example. If you've done immunotherapy to milk, how often do you need to keep milk in the diet? Because if it's a couple times a week, that's probably quite manageable. If you have to drink liters a day, then it isn't, right? And so people are really trying to figure out how much do you need to keep in the diet to maintain the effect.
Okay. Now, we talked a bit about age throughout your session. This relates specifically to adults. And granted that there's not as much research on immunotherapy for adults, but is there an issue with the therapy making allergic reactions worse in adults if they undergo this therapy?
Yeah, I mean, it's a great question. That hasn't, when you look at the averages, I mean, the immunotherapy tends to increase the threshold. So it does, it's just that some adults have too many symptoms and then they drop out of the studies. There hasn't been a lot of data that makes it look like it makes things worse. So it's more, can they tolerate it, and how much can you shift the threshold in more of a mature immune system. In the same way that an adult doesn't have a huge chance of outgrowing it on their own, they just don't seem to be, you don't seem to be able to move that threshold quite as much in the adult. But that depending on what your goals are of treatment, the CSACI standpoint was that it doesn't mean that you shouldn't be offering it at all to an adult. It's a careful risk benefit discussion of being clear about what do we think we can achieve, the fact that there may be reactions with this, and and then how to move forward from there. So it can work. I mean, there's no question that there are adults whose threshold can be increased with OIT. It's hard to predict who, and it doesn't seem as effective as in kids. Yeah.
Right. And so why is it that it's more effective in kids? What makes kids the different?
Yeah, I mean, I think we just think that the less mature, you know, a very sort of non-scientific answer is, you know, that the immune system is less mature, and we think that we have the ability to influence it more.
Okay. Now, we had someone ask about anxiety, whether anxiety is, think of it, is it a cofactor that might increase the risk of reaction or decrease someone's threshold of reactivity?
You know, anxiety is a huge issue, and people are just beginning to understand this more. One of the interesting studies that came out in the last few years was for even framing these reactions can make a big difference to how people think about it and their state of mind about it. So there was one study that framed the reactions that, you know, if you have an allergic reaction on OIT, they told the family that it meant that it was working, whereas otherwise they just did what they would normally do. And the people that sort of felt like, oh, that's sign that I'm doing something, that it's working, had a better feeling about those reactions, which is an interesting idea. So the way you think about it definitely makes a difference to whether you're willing to tolerate this process and willing to go through this process. And knowing that there could be reactions on it is really important to know. And so being able to switch the idea that they are in the driver's seat, that they are the one eating, and that they listen to their body, you know, all of these kinds of things can help. But really, we're in our infancy of understanding how to help people to shift gears, right? I mean, I think one of the questions said, you know, you've been told forever to avoid. How do you now eat it? And it's not right for everybody. So it's I think we will need that's just such an important area of supporting food allergic people, period, whether they're avoiding or whether they're eating it with immunotherapy. Just being able to have that feeling of control, because I think some of the studies really point to the idea that a lot of the difficulty is this lack of control, the fear. And for some people, OIT gives them the feeling of control. For some people, OIT is just, it's too scary to do.
Okay, so I'm going to wrap it up with one last question, and this one's really related to access, because we have some people asking, well, can I do immunotherapy at home? We've got, you know, family physicians that are asking, where should I refer people to families of food allergic children? So can you speak to this question of, you know, if someone wants to do immunotherapy, or a family physician as a patient that wants to do an immunotherapy, what is your recommendation in terms of how they should move forward?
Yeah, I mean, the availability is limited. There's simply no question about that. And you know, I think I have a slide in there. There's only 250 allergists across the country. So really, it's going to require some system changes to make it available. And I think what some of the research is trying to do is make these processes more manageable. And I think that's happening already, because I alluded to the fact that early OIT, people were trying grams and grams and grams. It would take so long to get there. Now people are really coalescing around lower doses. So there are protocol changes that hopefully make this less resource intensive. And then, but really at the end of the day, currently, probably the best advice is to refer to the allergist and, you know, see if they offer it. It's difficult. I wish I had a better answer for that, but currently I don't. And I guess the hope will be that as we improve the process, it will have less risk and it will be more widely available. But Great. No, you can't do it at home currently. And you do eat the dose, and then you increase, you know, under medical supervision. But you can't just sort of start this on your own currently.
Got it. Okay, well, you know, unfortunately, Dr. Upton, we've run out of time. We really appreciate the time that you took with us today. I do want to go back to the poll question. So, Dr. Upton, if you want to turn off your video, and I'm going to turn off mine. So if we can have the participants answer the poll here, that's if you had immunotherapy was available, would you consider it? So let's see what our attendees have said. Okay, the results are coming in. Just a few more seconds. All right, so we've got 47%, yeah, very interesting. So so a couple of thoughts on this, because I know there's that the unsure is a bit higher than what we had before. A couple of recommendations is to go back and take a look at our 2018 September 18 webinar. That gives you a little bit more detail around it. But clearly, you know, there's more to be learned about this. There's certainly access challenges. And there's lots of things to be thinking about as to whether this is the right therapy for you. So we thank you for your time, Dr. Upton. I just want to make a couple of notes around our Creating a Better Future webinar series. We still have one more webinar that's coming up featuring Dr. Moshe Ben-Shoshan on the 24th of June. It's about understanding when to use epinephrine. That is going to be very much a Q&A type format, so we would encourage you to submit your questions in advance, and there will be lots of opportunities for questions. Also, if you've missed some of our past webinars, know that they are on our website. The recordings are there, so we'd encourage you to go back and take a look at those webinars in addition to others that are outside of this series. So one more thing that we'd like to be able to do is just remind you that you will be getting a short survey through GoToWebinar immediately after this, and we'd really like you to complete that survey because it helps us understand what you're thinking around things like immunotherapy and oral immunotherapy, and it's good input for our organization to understand what sort of priorities are on your mind, and it helps us inform future webinar content. We did note that there were some questions around may contain that came up through the webinar series, and we will be taking a look at that as a separate subject later in the year. Okay, so I know that's an issue for the audience, and the more information we can bring to bear on that should be helpful. So I'd like to thank our supporters for this webinar series: Allergic, the Walter and Maria Schroeder Foundation, EpiPen, and the Sean Delaney Memorial Golf Classic. In the next few days, the recording of this webinar will be available at foodallergycanada.ca/webinars. Be sure to share this with others who may benefit. And I'd like to thank everyone for joining us today. This now concludes our webinar.